Today I'm talking with Dr. Rahul Desai from Portland, Oregon. He's the founder of Restore PDX in Portland and Beaverton, and he does interventional orthopedic medicine. Let's find out a little bit about it. Take it away, Dr. Desai.
Hi, thank you for having me.
You started out as a musculoskeletal radiologist, an MSK radiologist. So the transition, tell me about that.
Yeah, I think it was a natural transition. I thought I was going to be an orthopedic surgeon all through college, medical school, probably until third year of medical school. I did a rotation at, did a summer away at St. Jude's Hospital in Memphis, so the Children's Cancer Hospital, and went down there to work with Campbell Clinic in orthopedics, and loved the doctor. He was an orthopedic oncologist that I was working with, but part of the project was half orthopedics, half radiology. We were working on avascular necrosis of the hips after these children receive high-dose steroids and chemotherapy. Their hips the bone in the hips would die, and they would get collapse and degenerative arthritis really early. And so we're looking at evaluation and started to work with a radiologist down there, and just was blown away by imaging and kind of the technology, and then heard about interventional radiology, where you could use that imaging for diagnosis and treatments. So that really kind of spurred my interest. So last year of medical school, I switched to, instead of orthopedics, I wanted to do radiology with the knowledge that I wanted to do interventional radiology. And so I did my radiology residency, and then there's about 5 or 6 fellowships. So, study after the residency that you could focus on musculoskeletal imaging. So a lot of what the orthopedics is about. So reading MRIs, reading CTs, X-rays, and part of the fellowship was then also using imaging for interventions. So if there were, all of the spine injections or bone biopsies or spinal fractures or other types of bone lesions, anything to do with basically putting a needle somewhere, placing it using image guidance. That was the foundation of musculoskeletal interventional radiology. So I started doing that, and we did a lot of the standard steroid injections and pain management that you see. But that became pretty frustrating because we were getting the right, really good at getting the right diagnosis and figuring out where something was. And we'd put medicine there or anesthetic or steroids, and patients would feel really good for a while. But the problem was it wasn't very satisfying when patients come back after 3 to 6 months with the same problems, and we haven't helped anything in the long term, or the issue is getting worse and worse. And then we'd send them to, once those steroids stopped working, we see diminishing returns. So the first time you inject, it feels really good, it works really well, but eventually it comes back because we haven't changed the disease process. And then when it comes back, it's worse for the wear, and you treat it again, it doesn't work as well or as long, and then that's kind of a vicious cycle, and you see diminishing returns. And so we were looking for alternatives, and I'd heard about platelet-rich plasma at that time, and it sounded novel, it sounded a little bit crazy. I'm a little bit of a skeptic when you hear those things. This can help regenerate tissue. And that's just something you're not taught in medical school, right? That we hadn't been taught that. That was not a paradigm that we thought was real. And so I took it a little with a grain of salt. Didn't have a lot of other great options, and we had a lot of employees that worked at the imaging center that I'd worked at. So we started to, the company that had that product gave me some samples, some sample kits, so we could draw blood, spin it down, and inject it. And we talked to patients. So they were appropriate, not surgical yet, but in a lot of pain and didn't want any more steroid injections. So we treated them, and the first few patients came back after 6-8 weeks saying, "Doc, this feels fantastic. I have pain relief, and this is amazing." And so then we'd had imaging that documented what the issue was. One of the first patients that I treated had a rotator cuff injury, partial tear. So it was documented on MRI, significant tear. The treatment is rehab, physical therapy, and potentially surgery, or cortisone injections to alleviate the pain, but not fix the issue. So we treated this patient. They came back 6-8 weeks later feeling fantastic. We scanned them, and the tissue had healed, and I'd never seen anything like that before. So I sent the imaging back to my professors at WashU and St. Louis and said, "Hey, can you look at this? I haven't seen this. What are your thoughts?" And I sent it to a bunch of other folks, and nobody had any great answers because they hadn't seen it either.
So normally that would not heal.
Yeah. So that was the paradigm shift. The propensity of that tissue, or the natural progression of that disease process, is once that tendon or that tissue is injured, there is not a propensity for that to heal. Right? We look at menisci, tendons, ligaments, discs in the spine. The current state of medicine says those don't heal. That the acute injury may get a little bit better, but the tissue, once it's injured, it doesn't have the inherent blood supply to heal itself. So it's in this constant state of disrepair. Fellows and residents that have called, Restore Pediatrics have discussed with me about coming here and learning, because they don't, their programs don't offer this. So, with interventional pain management or orthopedics or sports medicine, the regenerative medicine is still considered a bit fringe because they're just getting data now. But I do think that the data is so positive and so overwhelmingly good that now they're realizing it. And I think there's a huge wave of physicians. Even 5 years ago, I would talk to some of my residents that I had when I was a fellow, and reaching out to them, and they basically said, "Oh, I'm calling BS on this. I don't believe that this works." I said, "Okay." I mean, you'll see. I'm seeing it every day, and when that literature starts to come out, because it's real, like we're treating, that you'll see that this actually does work. And now we're seeing that. Now I'm getting calls back from those same people. How do you start doing this? Who can I, what kind of centrifuge do you have? How do I start my own practice with regenerative medicine? So now they realize, wait a minute, there's data coming out in all of the major journals. There's, information that's coming out there. And then simply there's so many patients asking for it. We haven't advertised or anything for a long time, and we have lots of patients that come here. It's through purely word of mouth, right? That the patients are getting better. They're talking to their friends, family, community, and say, hey, this stuff is working for me. I didn't have to have a surgery. I got to leave with Band-Aids, and it fixed it. Right? And so I do think that and that's not just here, that's nationally, internationally, that people understand that for the right things and done the right way, this is a very powerful tool. It's not magic. It's not pixie dust that you can sprinkle anywhere and it's going to work. And that's, some of the concerns that we have as the field grows, is to make sure that it's done the right way. Because if everybody's doing this the wrong way, and there's a wrong way to do it, that you would have bad outcomes. You could have potentially people that are hurt, that are not made better, that feel like they're taken advantage of because it's an out-of-pocket expense. And so if you have that, then it's going to give a bad name to anybody that's doing this medicine. So that's a big concern of mine as well.
You've got verification of your patient results, but there aren't a lot of studies on this, are there?
But there's quite a few studies. I mean,
like the double blind, where they will actually be accepted by the medical community.
Yeah, I mean, there are peer-reviewed journals, right? So they have a process of having an article accepted to a peer-reviewed journal, and there are randomized, double-blinded, placebo-controlled trials out there that are showing efficacy and safety. And we know that it's really darn safe material to use done properly, but we're seeing that there's some nice studies for different areas showing efficacy. Right? And I think that's they're still small. They're not tens of thousands of people. These are ends of 50 or 100 or 300. But there's meta-analyses that are grouping these studies and showing that for tendon pathology that it's definitely effective. I mean, this is compared to a placebo or compared to steroid injections or hyaluronic acid or some of the standards that are out there. We're seeing better results with the regenerative medicine. There are registries that are popping up that are tracking thousands of patients and showing that there is definitely disease modification and reduction in symptoms.
So this is mostly suited to soft tissue, though, right? Is it a treatment that can work with bone tissue?
Yeah, so pretty much any tissue. So
really?
Yeah, you can, for soft tissue, ligaments, tendons, muscle, fibrocartilage, which is more difficult. It's not as doesn't respond as well because the blood supply is poorer. Cartilage, right? Bone works pretty well because bone is relatively well vascularized.
Yes, it has a blood supply.
Yeah, so it has a good blood supply. So if this has been used for, even just think about spinal fusions, they augment with bone marrow, they augment with, bone chips and things like that to allow for fusion or healing. So bone does pretty well. It's the subchondral bone, the cartilage, the hyaline cartilage, which is an extremely complex and organized structure. It's hard to reproduce that, right? But if you look at, meniscus, fibrocartilage, disc, we're seeing all those respond, not as well as, say, a tendon or muscle that's more well vascularized. One thing is to stratify the patient. So I think that's what we're looking at with the studies, we understand that this stuff works. I don't think that for most doctors that are doing it and doing it at a high level, we understand this stuff works, but there are failures. So we're trying to figure out, how do we limit our failures and how do we expand upon our successes? And a big part of that's stratification of the patients, right? When you look at certain injuries, there's 3 pretty significant articles that have come out for ulnar collateral ligaments in the elbow. So you see this in high-level pictures. So you've heard of Tommy John surgery.
Tommy John's.
Yeah. So for that, there's from 2013, there's a large article from 2016 and then 2017, all documenting significant success. I mean, the 90th percentile for ulnar collateral ligament injuries, which previously had been, a surgical indication. But what's interesting is what they're showing is that grade 1, grade 2, which are small tears or partial tears, but not complete tears, the PRP is working pretty well. I mean, 96% success rate on some of the studies. And when it gets to grade 3, and especially if there's a distal injury, so injury closer to the ulna, that the rate is near 0. So when you have those, and these are documented by MRI or potentially ultrasound, that those are not the right patients to treat. That needs to go to surgery, right? So don't waste your time. Don't waste their time because they're going to have a much longer recovery and rehab course anyway. Get them to the surgeon, right? But if you have a grade 2, it's mid-substance or proximal or grade, high grade 1, you're going to have a very, very high chance of success with PRP and a very regimented rehabilitation program, right? And I think that's what we're going to start to see across all the different injuries. That there's a lot of work being done on who's the right patient, how many do they need, what type of PRP, because not all PRP is PRP. Do they need stem cells? Do they need some other types of medicine? And then a big piece of this, the rehab, like what kind of rehabilitation program do they need? Because with soft tissues, even spine, you need rehabilitation. You need stress on the tissue for it to respond properly and to heal. And so all of those things are in concert.
How does a patient separate the reality from the hype? They're searching around on the internet and they've heard of stem cells. Everyone's heard of stem cells, and some people have heard of PRP. What are they going to find if they look around?
A lot of good information, but even more misinformation. The field right now is a very sexy field. Everybody wants to be in it. It's extremely potentially lucrative. And so there's a lot of interest in it. Unfortunately, there are a lot of folks out there that are using it. What I feel like is I have a biased opinion, but I feel like is the wrong way. It is truly more focused on how much money you can make rather than how you can help the patients. I don't like to badmouth other clinicians or other fields for doing things. Everybody has their own bias, and unfortunately, everybody has their own knowledge base, so they just may not know. But I do think that you have to ask yourself, and I've tried to think this through clearly, of how do you help a patient navigate this information. And I think the biggest things for me, if you stick with these, then you can maybe take the higher ground to discuss this, is you have to have proper diagnosis. So I have a 3-legged stool analogy, that you have this 3-legged stool of regenerative medicine. And if any one of those legs is not there, the patient's sitting on the stool and they're going to fall down. It's not going to work. You're going to have a frustrated patient, right? That's potentially a lot poorer because they paid all this money out of pocket. They're going to be frustrated. Their injury is not going to be helped. They've wasted time, money, and hope on getting this better, and that's not a good combination. And so how do you help try to make these procedures as successful as possible? So it doesn't matter who's doing them. How do you make it as successful as possible? One is proper diagnosis, right? Without that, we're throwing darts in the dark. We just don't know. So if you don't get so you have to take the time. You have to go to somebody that's a good clinician, that's going to listen to you, that's going to examine you, right? To do a physical examination, that's going to use all the tools at their disposal, including imaging. I'm biased on imaging, so I love, but watching how you walk. Is there some other issue? Where is this pain generator coming from? Using all those tools for diagnosis, and sometimes even diagnostic injections. We spend a lot of time doing injections with anesthetics just to see, is that where the pain is coming from? We block one nerve, we block a joint, we look, do different areas. Oftentimes for, say, a patient has knee arthritis, it's relatively straightforward. They have knee arthritis. When somebody comes in sometimes with low back pain, it could be a disc, it could be a facet joint, it could be the sacroiliac joint, it could be their hip, it could be myofascial. Where is it coming from? And you have to take a lot of time and deliberation to make sure that you have the right areas. That's diagnosis. The next is the biologic, right? So that's one leg is the diagnosis. The second leg is the biologic. What are you using? And I think that's called into question. We're still trying to figure out, what type of PRP to use. One example is when we first started using PRP, they were spinning, the blood, and it would be a dark red color. There were a lot of red blood cells in the PRP. It was high in platelet concentration, but it was also high in red blood cells and leukocytes and neutrophils. And so some of those cells were very toxic to the cartilage and toxic to the environment. Even though they had a lot of platelets, they weren't the best PRP for a joint.
I've read about the amber cells.
Yeah, exactly.
Yeah.
So you want an amber-looking PRP. So you're taking out the red blood cells, you're taking out the neutrophils, which are white blood cells, and it's much less inflammatory, and it's much less chondrotoxic. So those are actually toxic to the cartilage cells. And so when they did meta-analyses of different studies, they realized, because there were studies that were for PRP and there were studies that were against early on, and they're like, why is there such a wide discrepancy? Because the positive ones were really positive and the negative ones were really negative. And when they looked at it, they split across this, what type of PRP were they using? Were they using leukocyte rich or leukocyte poor, RBC rich or RBC poor? And it split in those. So all the successful ones were RBC, red blood cell poor, and leukocyte, the neutrophil white blood cell poor, but had lots of platelets. And they were working across the board. And the ones that didn't, they weren't working. And so as the newer studies start looking, hey, let's just stratify with this type of PRP across the board. It's very successful for intra-articular, for osteoarthritis. If you look at ligaments, tendons, soft tissues, muscle, then there may be some benefit of having a little bit more of an inflammatory reaction, having some of the white blood cells to activate that tissue. So there's some, that's why using the right biologic in the right area is really important. And now we're looking at different biologics, right? We're looking at autologous, meaning from the patient, so your own blood, or your own bone marrow, or your own fat, and you can process that to make the cells, this medicine to inject inside of you. Then there's autologous, so coming from another human. And so we have placental derived kind of afterbirth tissues. So these are live birth, donated placenta, so not embryonic, stem cells, but using the placenta, which they would throw away, for medicinal uses. And so lots of growth factors. There are stem cells. There are other things that are in there that could be very powerful medicines. The problem is we have to know how to use them properly, right? And so it's the same thing, the proper biologic. Right now, there's a lot of groups out there that are touting the benefits of these placental-derived stem cells. And, part of it is, are they using the right material? We're not sure. When they cryopreserve cells, somewhere else in some lab, and then send them to you, you have to thaw them. Number one, how are they processing? What's the sterility? What's the care these companies are taking? Because it's unregulated right now. FDA doesn't have regulation on them. So it's a little bit scary of what we're getting, because you don't know. When you do your own cells, it's in your own lab, it's your own tissue. You still have to maintain sterility and all those things, but it's your own tissue. When you're getting it from somewhere else, there's a little bit of an unknown. What are you actually getting? The amniotic stem cells that are coming in, I've talked to a lot of PhDs. There is potential value in this, but we're just not 100% sure of the safety. And then the second part's efficacy, because when they send them, they're sending them cryopreserved with DMSO. And DMSO is extremely toxic to cells, and especially when you're thawing them. So if somebody ordered stem cells, to say they're a cell biologist, right? You can order stem cells, and you can get them so you can study them. When they come into the lab, you take those cells, and there's a very definitive way you take them out of cryopreservation. So you start to thaw them, to room temperature, and you're adding a culture medium to those cells, and you're washing away the DMSO, because the DMSO will kill those cells. It's extremely cytotoxic. So there's a very staggered process of doing that. So you're kind of getting them unfrozen, and you're washing out the toxic material that they're preserved with. And even then, there's about a 30% loss of cells done the best way. So you're getting about 70% of 100%. When you do that in the office, or if you're going to some practitioner's office and they're thawing those cells, they're thawing them in their hand, right? And they're thawing them. The DMSO is mixing with the cells. It's killing off a lot of the cells. Within 7 minutes of the thaw, all those cells will be dead. So there's no viable cells going in there. So even if you had a lot of stem cells, and they're saying that they're giving 10 million or 30 million or 50 million, and they have to pay for the different amounts, that by the time that they're injecting, all those cells are dead. Okay, now, is it particularly dangerous? We don't know. We talked about the processing, but it may not be very effective. What you're getting is growth factors. So there's still growth factors in there, and the patients actually, they may get some benefit from those injections, like they may feel better, but the likelihood of why they're feeling better is growth factors. And the growth factors you can get from the platelets, you can get from, there are growth factors from amniotic tissue, but those are a lot cheaper. I mean, those are, the clinicians can buy those for several $100s. And so those are not a huge expense where you get into what they're charging for these, quote, stem cells. They're charging thousands and thousands of dollars. And some of the places, which is really frightening, is they're charging, if they get the stem cells for $1,000, they're charging $15,000, $20,000, $25,000 for these. So at that point, it becomes almost robbery. I feel like they're really not looking out for the best for the patients, and they're taking advantage of a lack of knowledge. Right? They have these seminars, they're feeding them all this information, and then they're taking advantage of folks that don't. If I went to the mechanic, I don't know anything about a car. He could pretty much tell me whatever they wanted, or she could tell me whatever, and I would probably believe them that the car needed that. So that's the last that has to be understood. And then the last part is the delivery, right? Mm-hmm. So you have to put it in the right place. So when you're injecting a knee or you're injecting something that's relatively superficial, if you're using image guidance, I think that's critical. That makes a big difference, right? You have to use for soft tissues, ultrasound, for deeper tissues, X-ray, for spine, for sure X-ray. And what I'm hearing in the community, which is a little bit frightening, is patients are going to some of these places and they're saying, "Oh, we're just going to inject it, where you're hurting," and the stem cells are smart, and they're going to be able to go wherever that you want to. And to a certain degree, if you inject it into the joint, that's true. But even when we do joints, we're more specific. Like if the ACL is degenerating, we inject the ACL. If the meniscus is injured or degenerating, we have to inject it into the meniscus to get even a chance for it to work. And sometimes even then, it doesn't work. Where they're talking about simply we can inject it here and it's going to fix everything. Their advertising says miracle cure, right? And the whole idea of this is that it's some magic and it's going to take the end stage, arthritis, and suddenly you're going to have a brand new knee. And that's frightening. These are empty promises that aren't going to happen. When we're talking to patients, we're very realistic, and that's the whole, the stratification. This is a medicine. It's a type of therapy. It has its good qualities, it has its bad qualities, and it has its failures. And I think that's, having those three things, those legs, will make it as powerful as it can be. But again, there has to be the realization that even with all that, there can be failures. And we have patients that are stratified that looks like they should be a home run, and we've treated them, and it hasn't worked. And that's frustrating not only to me, but obviously to the patient and to everybody that's involved in that care.
Obviously, you're passionate about this subject matter. You want the best for the patients, you want the best for the field. You want the field to develop and research to continue and success to continue. So, you're now on the board, soon to be vice president of the Interventional Orthopedics Foundation. Tell me about that foundation and what its goals are.
So the Interventional Orthopedic Foundation was a nonprofit, started in 2015 on the basis of allowing this medicine to flourish, but be done properly. And I think to educate the physicians of the right way of doing this type of medicine, promote its use, and also educate the patients to make sure that they have the understanding, the knowledge base to be able to make the right decisions and kind of navigate this field. And so those are the main tenets. It's been there was a large donation given by John Malone. So they were his family and the foundation were very generous in giving millions of dollars to the organization to promote this mission and kind of the values that are behind it. And I've been honored to be asked to be on the board. I think due to the work that I was luckily able to kind of fall into. I'm not at a major academic center. This was just something that luckily I fell into, and it's kind of when you see the light, it's hard to turn back from it, because you realize that everything else that you're doing isn't the right way to do things. And so you just can't ethically treat somebody with steroids when you know that that's not the right thing to do. Unfortunately, our medical education system has stuck with those tenets, and a lot of the doctors that are coming out, I feel like, are doing the wrong thing for the patient. And so it is really incumbent upon those that have seen the light or have understood that this is a much better way of doing things, that we need to get that word out. And so part of my mission is to help document this. So through all of why I've been able to, number one, gain some notoriety and some interest from other docs is that I took a lot of pictures, right? A lot of before and after. It's black and white, and nobody had seen that much of that type of work in this field before. And so now you look at a lot of the studies, and that they're heavily relying upon the MRI as a documentable proof of healing, right, before and after. And I think that's a really powerful tool, along with functional assessments and visual analog pain scores and all those things. But for me, as a radiologist, I'm extremely biased. It's black and white. It's broken and it's fixed. So we have to get the word out to the doctors in the community, the doctors that are in this field, because a lot of doctors doing interventional pain management and musculoskeletal, interventional orthopedics and those types of things that don't know about regenerative medicine.
Interventional orthopedics and regenerative medicine, you're separating those two.
Yeah.
Why are they separate?
Well, interventional orthopedics is going to be the larger umbrella. It may include some therapies that are not inherently regenerative in nature, right? But they are minimally invasive and non-surgical. So using ultrasound guidance, using needles or very small punctures to treat tissue. So one example would be the 10X procedure, right? So 10X it was developed out of Mayo Clinic about 10 years ago. It's a needle-driven procedure. So you use ultrasound to look at a diseased tendon. And a diseased tendon, chronically diseased tendon, is like a worn-out rope. So you have the brand new rope is a really tight twine, and the worn rope is kind of that furry twine that becomes painful, and that can slowly deteriorate and become larger tears and more dysfunctional. What this procedure does is you can isolate the area of injured tendon, make a small incision in the skin. You deploy a needle device. You drive it into the diseased tissue under real-time ultrasound, and you can hit it's connected to a machine, start the button. The needle vibrates at about 26,000 times per second. It preferentially debrides and breaks up the dead and diseased tissue, any calcium or necrotic tissue. And there's a lavage and aspiration at the tip. So right at the tip of the needle, it washes saline out, and then it sucks it back in. So it shoots it out and sucks it back in while breaking up this tissue. And so what you're basically doing is having a debridement, or it's like the demo phase. So if you want to help tissue heal, this is the demo. You get all the bad stuff out. It initiates a little bit of bleeding, and then your body over time, over the next several weeks, can actually heal. And what we're seeing is that even maybe without PRP or without stem cells, that tissue can go from a diseased state to a healthy state.
So that's the interventional orthopedics without a regenerative component.
Yeah. Okay. In and of itself, the process is regenerating. So that's the interesting thing.
But you're not adding a component of regenerative medicine.
No. Now you can. So what we have seen is that when you go in there and it's the demo phase, we're tearing down the bad part, and for the remodeling, the body can, a lot of times it can do it on its own, and there's a pretty high success rate. What we've seen by augmenting with growth factors, either from amniotic based or PRP or stem cells, that the tissue heals in a much more robust fashion and much more quickly. So it just kind of makes inherent sense that if you get rid of the bad stuff first and inject the good stuff soon after, it may not be the same day, but soon after, you'll get a much better tissue healing. The other components, before we had the 10X, we were doing maybe PRP or regenerative medicine for those same tissues. And what we noticed that would take a lot more effort or more injections to actually get that healing, because you were asking the body to go in, there's little cells, and they go in and kind of the Pac-Men and Pac-Women of the body and eat up the bad tissue. But sometimes that took repeated therapies that were relatively expensive to get rid of all the dead and diseased tissue first and then remodel. Here, we're expediting that process. We're going in and getting rid of it. And if the body has the ability to heal, then maybe you give it 6, 8 weeks, 10 weeks, And if the patient's healing on their own, then we just saved them the cost of doing this, potentially expensive regenerative medicine injection. If there's a more severely injured tissue, then we may want to have the discussion of, hey, this might help if we augment it. And then we're doing a study, we've done around 200 cases or so in the last year, and 30% of those cases we've augmented. The patients have chosen. We talked to them about the options and said, I'm going through this process. Is there a downside in doing the regenerative medicine with it? We feel that there's not a downside except to the wallet, right? But the cost. Yeah. And if it's able to expedite the healing, so we're looking at that data right now. We're seeing, at least the early trends, is that we're seeing that there's a much faster resolution of the discomfort, pain, and functionality at a faster rate. And then we're looking at the tissue structure with imaging. We're seeing that it looks better, heal, less calcium that's residual, some of the other morphologic factors and so we'd like to publish that data, and then we can really so this is a bit gestalt now, so we can really give numbers to say, if you do this, this is just, guesswork at this point, but you're cutting your recovery time by 30%, or, there's less repeat therapies. So what are the different parameters that might be affected by using the combination, kind of synergistic therapies?
When the 10X device was created, was that considered cutting edge?
Yes.
So that changed one approach to interventional orthopedics, because prior to that you'd have to go in and physically, manually debride something.
Yeah, it's called a percutaneous tenotomy. So they do those even now, where they make a larger incision, scrape the tendon, sometimes have to, cut the tendon off and then reattach the tendon to the bone. A lot of trauma, and the success rates aren't great with that. And there's just risk, right? More risk of infection, more risk of post-procedural pain, injury.
How widely used is the 10X procedure?
Not much yet. There hasn't. I think that there is some incorporation of it. Again, I do think that there is one of the issues is training, proper diagnosis, proper delivery, and so there is I hear of, even when I'm in the different surgery centers, and when some of the staff have watched what we do as interventionalists, and kind of the precision and localization of the needle, knowing where the tissue is injured, and delivering that needle into that tissue, there are differences in experience levels. And so sometimes when you have a interventional radiologist doing that, you probably have a better chance of getting into the right tissue.
But you could get into the wrong tissue.
And you can get in the wrong tissue. And so I think that the success rates, if you're putting these devices in the wrong hands, are going to be lower. And I do feel that that's probably one of the issues that's...
Well, and people do have traditional ways of approaching the problem of debridement, and they're not necessarily going to adopt a new way of doing it 20 years into their practice. You are willing to help lead and continue to develop the Interventional Orthopedics Foundation. What do you personally hope to accomplish?
The satisfaction of seeing, hopefully millions and millions of patients have access to a type of medicine that, makes them better with less risk, less downtime, less cost to society. I think that's probably the biggest thing that I'd like to see. I have five kids now, and they're going to grow up in this country, and I want it to be a successful country, and we have to curb medical costs. And not just the cost of the procedures, but the cost of downtime, the cost of narcotics, the cost of infections, the cost of missed time at work. I mean, all those things affect society, right?
How long until the insurance companies figure out that these quote-unquote experimental procedures that you are promoting actually will save that type of money and resources?
That's a good question. I think it's incumbent upon us as physicians that are doing this to prove it, right? We can talk all we want, but we have to prove it. And I think part of that is documentation of what we're doing, studies to show that it's better than the standard of care, and outreach to grassroots movements, to the community, to doing what we're doing now, to talk about this, to talk with legislators, to talk with the insurance companies. I mean, we have employees of insurance companies that are here that want to have these types of procedures, and are frustrated with their employers are not providing this. And I think we have to talk to their medical directors and have the medical directors be open to this discussion. It's not a farce, that it's actually working in the appropriate setting. And then, I think that's part of the desire of the Interventional Orthopedic Foundation, is to really show that this is working, to get the data, to publish, and then to have that movement that demonstrate that this is a very effective way. And I think, it's hard when these waves of medicine come. I've talked to some surgeons and things that have seen arthroscopy be developed and be, pretty game-changing. And this has been something that I know it gets a little bit poo-pooed for meniscectomies and some other things.
And just to be clear, the arthroscopy is the camera-guided small surgical incision type of approach to an orthopedic surgery.
Exactly. So arthroscopy is going into a joint with a camera and then a tool, and being able to work within that joint with, without disrupting it or cutting it open. That's what used to happen. I know, speaking with some of the surgeons that are a little bit older, especially ones that adopted that, there was a big push against that from the surgeons that were used to cutting open the tissue to see it. And so, well, you can't see it inside with the camera. You're not going to get the same exposure. You're not going to miss this, that, and the other. And there was a lot of hesitance, and I'm sure that they might have gone through, they didn't live through it, but maybe they went through the same. It'd be interesting to see kind of a historical perspective, or talk to some of the really early, because we're in an early adopter phase.
Right.
We're kind of the leading edge of doing this. And so we're having to go through the pain of making that happen. But it's interesting to see, with arthroscopy or other medicinal technologies that have, grabbed a hold and have been game-changing. The early adopters, what struggles did they have to go through, and what did they have to do to actually, allow it to work? And I think that like we said, the truth will be seen that this stuff is working. Along the way, it'll be interesting. I just hope that, the folks that aren't doing this the right way, I hope that doesn't preclude kind of the greater good from happening, because I think it is something that's fascinating. It works beautifully. It's elegant. It's simple. It's minimally invasive. There's much less injury. I mean, there's so many good things about it. We just have to make sure that because it's so relatively safe and easy, that that done in the wrong hands doesn't give it a bad name, and suddenly the FDA or legislation or the society says, hey, we don't want this stuff. It's a farce.
Well, I'm sold. What are the biggest changes in medicine that you have experienced?
Probably, for me, the biggest change in medicine that I've experienced is probably the introduction of biologics.
Okay.
What we've talked about. That was a true paradigm shift that we can actually, for me as a interventionalist and a radiologist, obviously the diagnostic capabilities have been known, so we're really good at figuring out what's going on. But when I first started, we were able to alleviate the pain for a short period of time, but we were not able to make any substantial, long-term, durable benefits for them, often having to send them somewhere else. So for me, the biggest change in my medicine has been the ability to help people long-term and to change their lives, and that's really gratifying to help people get better, improve the quality of their life, their functionality, and see how that affects all their different aspects of their life. So for me, that's been the biggest change, that we're able to affect quality, durable change for particular issues.
What are the biggest obstacles that you have found in this whole field, in being a doctor?
Yeah, we're running, I think, because of the newness of the technology. I had to start my own company to actually be able to do this with some degree of freedom. So working within another organization, we were doing this therapy. It was really taking off, and we were seeing wonderful results. But there was a backlash. This was an outpatient imaging center company, and I was doing it as an employee within that organization. They made their money on imaging, and they had a lot of referrals in from the community. And there were orthopedic surgeons at that time. I started doing this in 2008, and there were orthopedic surgeons calling in and saying, we're going to not send you any more business if you allow this physician to continue to do this, crazy medicine. This, it's not helping people. It's dangerous. It's not proven, and all of these things. And so while we were doing that and proving that, and I had received a grant from a large a company that did the amniotic growth factors to do a study. So this was a FDA approved trial. It would have been a definitely a landmark study to help demonstrate this was effective, and they wouldn't let me do it.
Ooh, ouch.
So and it was because of the worry that they were going to lose a lot of their business. I understand. I mean, they're getting that's you have to keep the doors open and do those things, and so that was one of the challenges. And we still see that today. Is I'll have patients come in. It's less and less, but over the past decade that I've been doing this, we've had a lot of patients come in and say that, hey, my doctor said that you're just trying to take our money, or this is unproven and it's not going to work, and if you're willing to throw your money away, then you should do it. And that's been personally it's hard to take. I think it definitely kind of leaves a bad taste in your mouth, and it's frustrating that you're trying to do the right thing and then you're getting hit on that end, that you're trying to fleece these patients, or this is you're snake oil salesman, or those types of things, when you're truly trying to, when you've seen the right way to do things and trying to promote that. That's kind of doubly frustrating. The second biggest challenge is just running a medical practice, which is extremely difficult in this day and age with insurance. The insurance company's goals are to make money, not to serve the patients, and so it's a really it's a two-edged sword trying to do this and navigate the insurance world with a cash pay type of business where you're working patients up, you're doing all the things you can so you can save them money, but then when it comes down to actually doing some of these therapies that are going to help them, it is something that needs to come out of their pocket, and it's even more frustrating when they can't afford it. Right? You've worked them up, you've documented what's wrong, you know what's going to help them, or what is likely to help them with a higher degree of success, and they're not able to do that because of lack of insurance coverage, and then they have to suffer through either like steroid injections, narcotics, or surgeries. And even more frustrating is when they come back and they're worse than they had been prior to a surgical intervention.
And you have had patients like that?
Oh, many. Yeah.
Wow. Well, you're obviously a passionate physician. What do you like most about being a physician?
The ability to help people. I think that's obviously, we all get a little bit jaded through the system, but I think almost any physician out there that's gone to medical school and gone through the trials and tribulations of doing that and working hard, I think there's a definite core of helping people. That's the main thing, that you want to help people that are in pain, that are suffering, that are ill, that are sick, and if you can affect that change, that's truly rewarding. And that is on a one-on-one basis that you get. I enjoy clinic. I was a trained radiologist, and I couldn't sit in that room and read images all day. That just wasn't me. I really enjoy talking to patients, love working. It's like a puzzle you're trying to solve, right? You have somebody come in and they're having this issue. You get all these different tools to figure out what's going on, and then when you get them better, it's truly rewarding. One, just maybe intellectually, like, oh, cool, you're able to figure out this thing, but then even more importantly, you're actually able to help someone in their life. So I think that's probably the thing that I enjoy most about being the successes. That when they come back and say, hey, this was awesome, you helped me. We treat a lot of degenerative disc disease, and the standard of care for that is pretty darn awful right now. Spinal fusion surgeries and other things like that, there are not a lot of effective therapies. And the rate of success that we're seeing with our stem cell therapies for intradiscal injections and those types of things are pretty phenomenal. And patients, it's probably the most painful procedure that we do. We're used to providing pain relief. This one actually can stimulate quite a bit of pain for quite a bit of time, but we're seeing very high rates of success, and they still get to leave with Band-Aids, right? And come back, and we're seeing the discs change, they're healed. And for some of these patients, if we start early enough, that it's game changing as far as longitudinally, that disc may never herniate again. It may not be painful, and in some senses, this may be a curative type of, not for everybody, but for a lot of the patients that we've seen, this is a curative type. I haven't seen them come back, and they're still doing well. And we'll hear from their, somebody else in their family that comes in, or a spouse, or hey, they're still doing fantastic. They had this therapy, and that's really rewarding to see. you can't treat in a box, or you can, but you're not going to have as good results.
Well, your original goal was
An institute.
with more different approaches to total health.
Yeah.
Okay.
So as we started to do regenerative medicine, it was clear to me that the healthier the patient, the better they did. Right? The better vascularity they have, the better microenvironment, the better response. You treat high-level athletes and they heal really, really well, right? You treat a brittle diabetic, not so much, right? And so I like to be successful, right? I like to be successful in my therapies. I want patients to be happy, especially when I'm charging them a whole bunch of money to do something. It changes the level of accountability in multiple times. It's not even probably
You mean having
calculable.
people having to pay cash
Yeah.
out of
So-
their pocket for things actually makes you feel more accountable.
Yeah. Yeah. I mean, I always feel accountable
Well,
to my
of course
patients.
you do,
But there's
but-
a different, I mean,
yeah.
I can tell you that I speak with other physicians around the country that don't do this. And there's a different level of accountability, even from the patients, that you go in and you have a procedure that's covered and it doesn't work. All right, well, let's try the next thing, right? Mm-hmm. And even with our steroid injections, if they don't work, they don't come back and they're not angry or, so for me, it changes the level of accountability that, hey, we're going to do this therapy that costs a whole heck of a lot of money at times. It's invasive comparatively, right? They're still leaving with Band-Aids, but it's invasive. It's painful afterwards, and then you need to devote a certain period of time and effort to try to heal that issue. And so when there's failures, that bothers me a lot. Like I don't, there's times I don't sleep well for several days after we have a therapy that doesn't work. I mean, it gnaws on me. I look back at what could we have done different. Should I have not done the therapy? And all those things that come to mind, right? And then I think that's a challenge with a lot of doctors that start in this field, is you have to give them the sense, because it's really tough when the first maybe 2 or 3 they do don't work. Either for one of the reasons, maybe they don't have the right diagnosis, maybe it was the right therapy, maybe it was just bad luck, And then when you have a large N, when you've seen it done over and over and over again, and you have that 70-80% success rate, then the 20-30%, even though you don't feel good about that happening, you realize that that's just part of the process, because that happens in every phase of medicine. There's lots of surgeries that don't work. We see the aftermath of those. And the one thing that we can say with the regenerative medicine is we don't make people worse. Like, knock on wood, it hurts for several weeks, sometimes worst case scenario several months. But with the regenerative medicine, I haven't seen anybody get worse forever. Now the tissue might continue to degrade. It's not going to heal. It's not going to get better.
It's not because of the regenerative medicine.
But right. We don't see that all the time with surgery, unfortunately. I mean, we see patients that went in with one problem and come out with a lot more, or much more severe, not because of the inherent issue that's worsening, but a new problem that was created by the surgery, right? And so that's where I feel like when this gets covered, it's going to be a very clear delineation of, look, we're going to do this therapy. If it doesn't work, you can move on to the next one. And so that's where I feel like with the steroid injection, you do it, if it doesn't work, okay, we tried it, let's go on to the surgical intervention. And I think eventually this will play a role, but what we're going to see is, instead of it failing most of the time like cortisone does, or potentially accelerating the path to a surgery, that we're going to be able to remove 40, 50, 60, 70% of the patients from that pathway. And with the baby boomers, the orthopedic surgeons have no worries. There's going to be lots of surgeries. There's going to be too many, right? And so this really needs to be, that's the way to think about it. I think that there is some trepidation, some fear that they're not going to have enough business. But if you look at all of the statistics and all the numbers, we're going to have such a massive patient population to treat. That's not a worry. We have to treat them properly, right? We got to stratify, and so the people that don't need it don't need to get it. Let's get them off that pathway. And I think that the earlier we start, the more significantly we can change that disease process. I don't think it's going to forever hold off some patients. They're going to need joint replacements, or we're going to need surgery. We're going to need wonderful spine surgeons and neurosurgeons and orthopedic surgeons. That's never going to go away. Definitely societally, we need this type of medicine.
Is this something that, even without a sports injury, you would possibly look at for younger people?
Yeah. Oh, of course. I mean, we see a lot of patients with dysplasias and some, it's not just sports injuries. Just sometimes, unfortunately, congenitally, there are certain things that you're predisposed to early arthritis. A lot of it's genetics. I mean, you have, when that gene turns on, that gene expression turns on, it is what it is. And so I think that, we have some predispositions from our parents that we can't help. And if they are more catastrophic in nature, then they're going to be really tough to deal with. And I think that's where this can step in and help quite a bit. And we've had some patients that have severe dysplasia, and I've been absolutely shocked.
What's dysplasia?
So dysplasia is a misshapen hip, dysplasia of the hip, a misshapen hip that's congenital.
Right.
And they have, in their 20s, have developed severe arthritis.
Oh.
And they're too young to really have a replacement.
Mm-hmm.
They're placed on narcotics, physical therapy, and then they're just told to wait and live a limited life, with severe pain and change, their activity modification. And so these therapies, I've been shocked that we've done stem cells for them, and I didn't even expect that type of recovery. I mean, these patients are running. I don't want them to run, but some of them are running again.
Wow.
And it's profound at the difference. So when you look at osteoarthritis, there's two components. One is mechanical, right? So you have a square peg in a round hole. You've lost some structure. You have increased friction, swelling, pain. But part of it's biochemical, and that's where you see, like, when these genes are turned on. Like, for no reason someone develops arthritis. They've lived 65 years, 60 years, doing great, or 40 years, right? And they're doing great, never had any injury. Suddenly their hip starts hurting, or suddenly their knee starts hurting. What happened, right? And then you see the progression. You see a 40-year person that has a X-ray or MRI at 40, knees just starting to hurt. Usually don't get an MRI, but X-rays, it looks basically perfect. A little swelling maybe, but it looks pretty darn good. And I've seen that within a year. Nothing. They get a steroid injection, they get some physical therapy, they take a bunch of NSAIDs, and then a year later, you see frank arthritis. I mean, it's obvious. They've lost, 40, 50, 60% of their cartilage within that year.
And that would be a gene expression?
Yeah. So a gene gets turned on, right? And what happens when the gene gets turned on? Those cells start to produce certain proteins, certain cytokines, certain interleukins. I call them evil humors, right? They suddenly start to produce these evil humors, and the joint gets toxic.
Really?
It's acidic. It's an angry environment, and it starts to break down the cartilage. And you start to send down this, you have anabolic is building, and you have catabolic. You send down this knee into this catabolic pathway, and you have to stop that. And so what we're realizing that a lot of times with the regenerative medicine, it's not that you're going to put in regenerative medicine and brand new cartilage is going to grow and it's a brand new knee, but it's simply you're stopping that breakdown. You're changing those gene expression, right? So when you're injecting the stem cells, they release these things called exosomes. We're learning more and more about them. They're little vesicles, microvesicles that are released from the healthy cells, and they go and they start to affect the unhealthy cells, and they change their gene expression.
So they can be like little triggers or activators for other processes. It's not that the PRP or stem cells are going to do all the work, but they're going to encourage cells around them to do some of the work. It's like an on switch.
Yeah.
That's a piece of what's going on here.
Yeah, one of Dr. Arnold Kaplan has kind of coined the term MSCs. He changed that, MSCs are mesenchymal stem cells, and we used to think that they'd go and, they become new cartilage, they become the other cells, and they regrow. And he coined the term medicinal signaling cells.
Ah.
So you inject them, and they're actually, a lot of the work that they're doing is simply re-energizing the joint and the body to help that area to heal, to change gene expression, to reduce the cytotoxicity of the joint and what's happening. One, slow down the progression of the arthritis, and then in some cases, if you're lucky, maybe reverse some of those changes.
I needed you about 20 years ago.
We all needed this medicine. Yeah, and so that's why the passion that I have for it, because we know that it's working. It's so simple and so easy. Now we just have to get, on the megaphone and shout it out to the world that, hey, this is a powerful medicine that should be utilized. And for me, it's a struggle when I hear we have to go through all these studies and rat models and 10 years of, and it's a struggle because patients need this care now. And it should be done properly now, and it should be, it's so safe and simple and elegant compared to the alternative. I think if we had something that was so safe and easy that worked better than this, then I wouldn't be talking about this. But, doing invasive surgeries or having patients on narcotics, that's not better than this, right?
No. So how do you get the word out?
like we're doing now. I think part of it is grassroots. We have, social media that's really powerful to get that message across. The Interventional Orthopedic Foundation, utilizing, thank goodness that there's people out there that are generous with their money that are going to help the cause. And so now it's incumbent upon us to really use that money wisely and get out the message that this is a powerful therapy done properly, and that you want it done with, insight and ethics. And so hopefully, that's a big part of it. And then the research, like we have folks that can help us tremendously. We have a lot of like my practice, we have a lot of internal data. I've been doing this for almost a decade now. I've treated thousands of patients, and I haven't published anything, and that's my fault. But I can't run the practice barely, and get out the information and do this. I'm not an academic institution. I've talked to OHSU a little bit about hope, and we have been in discussions about getting some help. That hasn't, we've been talking for a while. We really need to get some traction on that, and I've just spoken with someone that might help us. But simply, delving into the data and getting it out there. And part of, what I do is I, travel around the world and I speak, and I'm hoping that what I can show other doctors is that this stuff is working. And if it gets into the sphere of influence that allow others to, be more excited about this and actually be in a position where they do research to look into these studies, because they know that, hey, this is, like, for me, it's my practice is proof of concept. We've done it, we've documented it, we've shown it, I've spoken all over the world.
How are you getting invited out to these, to speak?
Well, I got lucky. I had been taking a bunch of pictures before and afters, treating patients, seeing phenomenal results, and went down to a conference. And as you know, that's obvious from this video, I like to talk. So the person that was putting on the conference, Steve Sampson in LA, he was, I forget, 2009, and he had put on a small conference. There was probably 30 people in a small hotel in Los Angeles. They presented, and everybody was talking about kind of VAS scores and this and PRP, and it was pretty basic. And he walked by, and I said, "Steve, have you seen anything like this?" And I showed him my before and afters, and he saw those, and he was pretty blown away. He said, "Okay, you need to come back in a couple months. I'm holding a much larger conference. There's going to be a lot of international folks and academic institutions, and those that'll be there. Can you present this data?" And I said, "Yeah, I have this and another 30 cases." So I went up on stage, and this random radiologist from Portland, Oregon, I went up there, no academic standing, and so I showed the cases and said, "This is a patient that came in with this. We had beautiful imaging, right? 3 Tesla MRI, top-notch quality, and we had followed up everything pretty closely as far as imaging, tracking the changes. And it was purely interest. I was very interested. So I kept taking pictures, just sequentially.
And you still have everything. You have all this categorized, so you can.
Mm-hmm.
Yeah.
Yeah. So that's a nice thing. Everything's on PACS. It's archived, and then we have an EMR. So but somebody has to mine it. That's the hard part. Is to mine it,
right.
Go in. I mean, it's just a huge amount of work to try to do any publications to do that. So we have some interested people that are out there. A lot of this is kind of philanthropic that want to get the message out there. I spoke with a PhD this weekend, and she's going to be coming in here, and she's seen some of the cases, especially for spine, because there's not a lot of data out there. And so we really there's a lot on joints and tendons and more. It's just pouring out. I mean, if you look at PubMed every week, it's just hard to keep track of. So it's exciting. I mean, this field is really catching fire, and it's not just a few people that are doing it. The big thing I think now we're trying to kind of tread that line is for the Interventional Orthopedic Foundation is how do you call out bad actors, and how do you make sure that that you keep the public safe from this stuff. Mm-hmm. And so where is that line of being overly aggressive of you want to kind of maintain the high road, but how do you make sure that things are done properly? And I think for me the discussion is just show the level of care, the level of training that it takes to do this the right way, document the heck out of it and show that, and educate the public, right? Talk, do through social media, through YouTube, through whatever means that you have, educate, and then arm those other doctors that are in the foundation. So there's members that are joining the Interventional Orthopedic Foundation. What I'd love to see is that we arm them with the right kind of tactical information to document why that they're, or to within their individual communities, to show how why patients should come to them, or why should patients seek out not in, it doesn't have to be them, right? It's just tell them this is the right way of doing things. Does this make sense to you? Diagnosis, biologic, delivery. Show them the pathway, and then say, make your decision. Go talk to look at two or three opinions, and then who's doing it the right way.
One of the goals of your foundation then is to standardize training.
Yeah.
And to recruit more doctors into the field.
Yeah.
Because it sounds like it's a field that needs more of everything.
Yeah. So there was over, I think, $150,000, $160,000 worth of scholarships. And I have this PowerPoint presentation, so I can give that to you. That documents what is the IOF, and it has discussions that a lot of the money that's being utilized. We have the large conferences, and like Dr. Manning and a lot of other residents in training from around the country were given free conference attendance, flight, meals, hotel, and it's really to recruit the next generation. And what's exciting about the IOF is the lack of bias. I think there was a concern. It was started by Dr. Chris Centeno. He is of Regenerative fame, founder and past CEO of CMO now of Regenerative, and they are kind of the 800-pound gorilla in regenerative medicine. Mm-hmm. He is somewhat of a polarizing figure, very opinionated, brilliant guy, but has his opinions, right? And he definitely has sometimes rubbed people the wrong way. I think there was a fear when he started this organization that it was an organization to promote that way of thinking only. And I think that he's shown by recruiting a lot of really intelligent and unbiased physicians to the board, and also now the leadership with Dr. Malanga and myself going forward, that it's much more open source, unbiased, and really pushing the field to have a broad perspective and not focus on simply one way of doing things. It's kind of open source.
Do you feel that you're an innovator in this field? Do you actually pioneer your own techniques and ways to extract things and use tools, or do you follow things that you've learned?
I think if I were to say, innovation would be the blending of the radiology with the tools that we have.
So are most of the interventional and regenerative people using the imaging tools with your proficiency?
That's a loaded question, but I think on the diagnostics, the vast majority aren't. I think if you look at the skill set that I have, I think in certain kind of blending them, I think I'm,
You're higher level with your radiology and imaging background.
Yeah, I think there's a different way of looking at things. I've read thousands and thousands tens of thousands of MRIs and examined those patients, right? And so there's a unique position there that you have a very high level skill set of evaluating and looking at imaging, and then I have to, put my hands on the patient, examine them, and then sometimes correlate that back with the imaging, and then inject them and not have any benefit, and then review the imaging, and that has become something that is a very unique skill set, and that's not the norm. So in that sense, I definitely have developed a different set of skills and competency that's not the norm. Like most radiologists, you're looking at an image, you never see the patient.
And
right?
most orthopedics who read an MRI are not radiologists.
Yeah. And a lot of, unfortunately, the anesthesiologists or some of the others in the field, a lot of them won't read the MRI at all. They'll read the MRI report, and it'll say one thing, and they'll treat that.
I can tell you just from experience that different physicians will read an MRI differently than from one to the next.
Well, I would say that even in the radiology realm, I read it differently than the other radiologists. Even a fellowship-trained MSK doc, when they're reading a spine, I read it differently. I'm looking for certain things that are pain generators that I have picked up on, over the years. Even simply as our spine protocol, we include the SI joints. And I'm looking at the sacroiliac joint. I'm looking for effusions. I'm looking for any ligamentous edema, things that just don't get mentioned. And I can tell you, every week I look at outside MRIs that are misread. They're not read properly, right? And there are things that are missing, and especially for the patients. But I have a unique situation. I'm lucky that I get to sit there and talk to the patients for 30 minutes and then get to look at the MRI, and suddenly things pop out that you don't see when you're in a basement of a hospital reading it, or you're reading it, Nighthawk or something else. So I think there's a big schism between the clinicians and the radiologists. So definitely that is a unique skill set that I've gained. Now, all the other things, I've just been lucky to learn from other people. Like, I'm not a cell scientist that's figuring out, hey, this PRP stuff works. I'm not the first person to understand how, stem cells work or anything like that. I'm taking this technology and then implementing it. And some of the things that we do are novel, but I would say, if it hadn't been for physicians before me sharing that information, then I wouldn't have ever learned it, right? So it's definitely, and that's how, you have to be kind of open source and talk to everybody and tell. And that's why I've spoken all over the country and at these different meetings, and I don't hold anything back. I'm telling them how we're doing stuff. It's not proprietary.
But I think you might be onto something with a subspecialty in imaging and regenerative medicine.
Oh, yeah.
Because the high level of both
Yeah.
is possibly the best way to apply this.
Well, I'd like to start the website. I told you, kind of regenerative.radiologist.com. I bought the thing.
Congratulations.
Yeah, so finally it was $9.99 on GoDaddy on sale. And so I think that there is an opportunity there to really teach other docs how to do the medicine correctly, how to interpret the imaging, but then to utilize the skill set that you have inherently, because we're really good at putting needles in places, and we're really good at imaging, where I kind of know their blind spots, right? And so the 10 years of work that I've done to get to where I am, I'd love to be able to share that and expedite that learning process.
Right, condense that, for sure.